All right, we're gonna go ahead and get started. So thank you everyone for joining us today for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. Thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engage in the session, keeping your cameras on when appropriate, registering for CME credit for each session, and completing and submitting a session eval form. The next slide, please. So the activity code for today is 10093242, and the instructions below are how to get your CME credit via text. I'll leave this up here for a little bit so you can claim that. All right, next slide, please. And again, this is just instructions on how to get the CME credit via text. Again, the activity code for today is 10093242. Next slide, please. And then this is just information regarding how to access your CME transcripts. Next slide, please. And this is information regarding the AAFP credit system. Next slide, please. And these are the core competencies that our Grand Rounds addresses. Next slide, please. Dr. Tina Beck has no financial relationships with ineligible companies to disclose. Next slide, please. And Dr. Shi will give us a brief introduction. Thank you.
Hi, it's my great pleasure to introduce Dr. Tina Beck, which we all know and worked with and love. So Dr. Beck had graduated Campbell University in North Carolina in 2011 with her doctorate in pharmacy and a Master of Science in Clinical Research. So after graduating, she worked at an independent pharmacy near the beaches of North Carolina for about a year. She completed 2-year pharmacotherapy residency at the Beck School of Pharmacy, UIW, and joined the faculty team in 2014. So her areas of interest are infectious diseases, anticoagulation, heart failure, and nephrology. So Dr. Beck is a member of American Society of Health System Pharmacists, Texas Society of Health System Pharmacists, Central Texas Society of Health System Pharmacists, the American College of Clinical Pharmacy, American Association of Colleges of Pharmacy, and Phi Lambda Sigma Pharmacy Leadership Society, American Pharmacists Association, and Kappa Epsilon. She's a board-certified pharmacotherapy specialist. So without further ado, we'll have Dr. Beck talking about her favorite topics of antibiotics primers for primary care. Thank you.
Can everyone hear me?
Yes.
Okay, perfect. So today, I'm more inpatient, but I was asked to talk about outpatient infections that as primary care physicians, you probably will be seeing the most. I do have learning objectives. I'm not going to read this all to you because as I was putting my lecture together, I realized I had a very lofty goal of trying to cover all these infections in 1 hour. So this will be a little bit fast. I do have some polls throughout the presentation just to keep you guys engaged. It's pollev.com/TinaBeck899, or you can send or text message 22333 and my name of Tina Beck 899. And this information will come up on the slides with the polls. So here is my first poll just to get you guys into the system. But how comfortable are you treating different infections? I know infectious diseases is not a common or an exciting area for both pharmacists and physicians unless you are in ID. So just in general, again, are you very not comfortable with infections, somewhat comfortable, or when in doubt, just prescribe Cipro? Well, everyone and I have a love-hate relationship, and today decides to hate me. Let's see, let's try that again. If poll everywhere is not working for you, you are more than welcome to put it in the chat as well.
It says waiting for presentation to begin, like on the poll website. I don't know if that's everyone or just Android, but I'll do it in the poll.
Apple too. Don't worry, Alyssa.
Okay, so again, poll everywhere and I have a love-hate relationship and lately it's been hating me. So if you guys want to put it in the chat or unmute yourself, please feel free. And again, there is no right answer to this. Okay, I see somewhat. I see not comfortable. Okay, I'm glad no one's picking just prescribe Cipro when in doubt. So this is just a common approach or a general approach to treat infections. This little circle wheel is actually from the Joint Commissions of Pharmacy Practice, but I looked at it, I'm like, it doesn't just have to be related to pharmacists. I think anyone can relate to this on how to just approach infections or any disease state in general. So first thing you need to ask is what is the most likely cause or culprit of the infection? And then 2, confirm that there is an infection. And then we may be getting cultures and we may not be getting cultures. So again, knowing when it's appropriate to say, like, let's get cultures versus sometimes it's not appropriate and we may be just charging patients more money for something that's not going to give us very useful information. Select antimicrobial therapy if needed. I say if needed because we're going to talk a lot about viruses. And I do have a cup. I don't know if you guys can see my little cup, but it says talking to me before my coffee is like taking antibiotics for viral infections. Do not recommend. That is one of my biggest pet peeve. And then monitor response and optimize therapy depending on what you choose for your selection of drugs. So I'm going to start off with upper respiratory infections. I did not include otitis media because I hope everyone feels pretty comfortable with ear infections in children. But I'm going to talk more about rhinosinusitis and pharyngitis. So we're going to start off with rhinosinusitis. It's one of the most common reasons for prescription antibiotics in primary care. Actually, it's the 5th leading cause of antibiotic prescriptions in primary care. And both children and adults are both impacted by this. I don't do pediatrics, so I do refer a little bit to some pediatric guidelines. But again, when I'm talking about this, I'm talking about adults. So first thing we need to do again with that stepwise process of the wheel was confirming infection. And per the IDSA guidelines, which are 12 years old now, they say if you have 2 or more of the major symptoms or 1 major and more than 1 minor symptom, this may be saying that you may have rhinosinusitis of some kind, whether it's bacterial or viral. We'll talk about that in a second. But the major ones are going to be more of that anything that relates to pus that looks purulent, we're going to say it's bacterial, or it's a major sign that you have an infection up in the sinuses. As you can see, for some of the other ones that people may complain about with sinus pressure will be like ear pain or dental pain where they feel the pain in their teeth. Fever is interesting because I didn't go too much into the different types of sinusitis. There is acute sinusitis, there's subacute and chronic. And depending on the length of symptoms that you have, fever can fall into a major symptom or a minor symptom, depending on what kind of sinusitis you have. And then the loss of smell or low smell is another major symptoms. So again, these are just signs and symptoms, but if you really look at it, all these symptoms, you're going to be like, it could be a virus. It could be a bacteria. Don't know. And so what we want to do for bacterial rhinosinusitis is it starts off in general with a upper respiratory infection of some kind. And what we're looking for is persistent illness with daytime cough that's lasting for more than 10 days. So this is the key thing about bacterial sinusitis is this persistence of symptoms that won't go away after a week. Worsening course or double sickening, which means the patient had symptoms that we just listed before. They start to feel a little bit better and you're like, okay, I'm getting better. And all of a sudden they start getting the symptoms again. So this is what we call a double sickening situation. And then severe onset, which is considered fever greater than 102 with that purulent nasal discharge for more than 3 days. So this is when you would consider potentially this being bacterial versus more viral. And then the next step was like, do you need cultures or imaging of any kind? And per the guidelines, it's not recommended that you get cultures at least. Because if you think about how are we going to culture the sinuses, it's a little bit too invasive for patients to be like, let's culture what's growing up in there. And then if you want to run a respiratory viral panel, you can. It's not required by the guidelines, but think about the seasons that viruses happen. So we just got out of the pandemics. I know everyone was testing for COVID anytime anyone had anything respiratory. Flu season, we are certainly in the middle of flu season or the tail end of flu season right now. So if you're in flu season, you can always check to see if they have the flu, rhinovirus, RSV. You can always do those if it's in the season for it. Granted, there are viruses that, flu can show up when it's not flu season. But again, if you think that more likely a virus is causing this and you want to confirm, just so if you're not prescribing antibiotics, your patients are not mad at you saying like, I came here and you're not giving me anything for it. You can just be like, it's a virus. You just got to let it run its course. So again, the most common cause is going to be viral infections for sinusitis. Children are usually the ones that bring home the viruses. My kids are Petri dishes, and they always give me everything they get from school. And most likely they picked up the upper respiratory virus, whether it's influenza, rhinovirus. Luckily, my kids have never given me COVID, but it's usually a virus that starts up here. And then if you are worried about bacterial, when we talked about bacterial sinusitis symptoms, your main ones are going to be H. influenzae, strep pneumo, M. catarrhalis. Pretty much the three that are bigger are going to be in your top three. The order of 1, 2, and 3 may change slightly depending on which infection we're talking about. But in general, the top 3 above the diaphragm, H. influenzae, strep pneumo, and M. catarrhalis are going to be your top 3 pathogens that we need to worry about. I made Staph aureus a little bit lower or smaller in font just to say it is something to think about, but it's not my first thing when I think about rhinosinusitis being like staph is causing this sinus infection. You got to think about, when do you think about staph as a potential cause of sinus infections? Are they colonized with MRSA in the nair? So I am not saying by any means to MRSA nair every single one of your patients in clinic to see if they have Staph aureus in their nasal cavity. But, did they have a history of Staph aureus respiratory infection recently? But again, unless they have risk factors for Staph aureus is not one I think about for up here. H. influenzae, so the order here is H. influenzae is probably more likely to be causing your rhinosinusitis, and then strep pneumo, and then M. catarrhalis, Moraxella, is probably your third one. It's not as common as H. influenzae or strep pneumo. And this is important because when we're going to talk about our antibiotic choice, we're going to really be targeting H. influenzae and strep pneumo, and then our drug of choice actually does target M. catarrhalis pretty well, but again, it's lower on my priority list. So again, viral versus bacterial, as you can see between the two symptoms, they do run pretty similar. But the reasons why that persistent symptoms is important is because a viral infection usually will self-resolve in 5 to 7 days. Once you get to that 10-day mark, we're going to probably say this is a little bit too long for it to still be a viral infection unless you got a second viral infection on top of your first one. So if, again, the key thing is that 10 days of persistent symptoms as one of the reasons to say this is bacterial. And again, patients may come to you on day 5 saying like, I just feel miserable, give me something. But knowing that, again, it may still be too early to say it's bacterial, again, unless you have that double sickening or you meet the severe criteria of the fever greater than 102 degrees Fahrenheit, and you have that, it's an and statement, and you have that purulent discharge from the nose. So again, I don't think pull everywhere may not work. We'll see. But let's say just in general, from what you know, what for your medical school training and practice that you've been doing, What is the first line treatment for patients with acute bacterial rhinosinusitis and assume they have no allergies? No drug allergies. I see Augmentin. So far people are saying Augmentin. I am very pleased. Let's see if it'll show you the correct answer. Nope. We'll do that. So it is Augmentin. And I did put an or statement here, but the IDSA and the pediatric guidelines do recommend Augmentin or amoxiclav as your first line option. I did put an or statement here because the 2015 guidelines for the head and neck surgery do say amoxicillin is their preferred drug of choice. However, the reason why I put a gold star for amoxiclav is that H. influenza, which is probably my #1 cause of causing rhinosinusitis, we are seeing more resistance to it in regards to its producing beta-lactamase to help that breaks down amoxicillin. So adding that clavulanate to it is a beta-lactamase inhibitor. So it's actually working against the resistant mechanism that H. influenzae has developed against our antibiotics. So this is why IDSA and pediatrics is saying go Augmentin first line. The 2015 guidelines are saying amoxicillin is more narrow in coverage compared to Augmentin. It is, and it has less side effects compared to Augmentin, and it does. So they're saying that they still feel comfortable going, giving a little bit more friendlier antibiotic than Augmentin as their first line choice. But we are again seeing that rise of H. influenzae resistance as well as strep pneumo resistance on the rise here in the US. So I'm going to follow the IDSA guidelines right now and recommend that you go Augmentin as your first line therapy. So per the guidelines, and this is assuming normal renal function, if you have no risk factors for drug resistance and non-severe infections, you will give the 500/125 or the 875/125. And for adults, we go a shorter course. We go 5 to 7 days. And for children, it's 45 mg per kg per day in divided doses. You're going to do it BID. And because they're children and the exposure that our children have to other children, again, with these germs that they're passing back and forth to each other, the duration is going to be a little bit longer of 10 to 14 days. You can see that there is a super high dose of 2 grams of Augmentin BID for adult patients who are at risk for drug resistance or have that severe infection, again, that 102 fever and purulent nasal discharge. When you think about 2,000 milligrams BID of Augmentin, you just can't help but think about all the GI side effects that the patient is going to experience. But again, because of the problem of resistance that we're seeing globally, we sometimes need to push the dose to try to overcome what the bacteria are doing to beat our system. And so you're going to be like, what's the risk factors for drug resistance? And the different risk factors to think about of whether your patient gets the standard dosing of Augmentin versus if you need to give them that 2 grams dose is that they had previous antibiotics in the last month. And this is PO or IV. This is a clear differentiation between some of the other infections I'm going to talk about. Less than 2 years old, again, because they probably are getting it from daycare attendants, you don't know what other children or parents are exposing their children to for regards to antibiotics. So you're again, the petri dishes of the germs spreading back and forth. Your kids is picking up Susie's strep pneumo from 2 weeks ago. We don't know. You probably will be giving a little bit higher doses of your antibiotics if you are immunocompromised. So active chemotherapy, HIV, high dose steroids. You may want to consider upping your antibiotic dosing just again to make sure that we don't prevent them going into severe infection or requiring hospitalizations. Multiple comorbidities that include chronic heart, lung, liver, and renal disease. For your chronic heart, I do want to emphasize hypertension is not a chronic heart disease. Yes, it is a problem that can affect our heart in the long run, but when we say chronic heart, we're meaning like something that's coronary artery disease, heart failure, something that is actually structurally wrong with your heart versus just hypertension, because again, patients may have hypertension for a while before it actually does any effect on their heart. And then diabetes. So, here in San Antonio, we have our huge diabetic population. You may want to consider upping your dose for your diabetic patients. There is controversy about, does diabetes make you, quote, immunocompromised? And this is why we need to up the dose. It may also just be related to diabetic patients are at more risk for, depending on how uncontrolled their diabetes are, fighting infections may be harder because of uncontrolled sugars. So this is why we may want to increase the dosing. And then your strep pneumo prevalence, the resistant strep pneumo prevalence. To find that information, you may have to look at your antibiogram just to see when you go to strep pneumo and you look at augmentin, how prevalent is it that augmentin will work against your strep pneumo versus not. For our UH patients, you can look at our antibiogram on Epic, and it does have both outpatient and inpatient information. If you are outside the UH system and you're like, I don't know where our antibiogram is, or if we even have one, that may be a little bit harder to find for you to determine if you need to increase your dosing for your antibiotics. And then we always get the question of the penicillin allergy, what to do. This is a huge problem that, IDSA is trying to address as well, because we just have way too many patients with this penicillin allergy that's flagged into their chart. I think if you see a penicillin allergy, you really do have to ask yourself, what was the reaction? How long ago was the reaction? And there's more evidence coming out of potentially challenging these patients with penicillin, depending on what their reaction was. But your type 1 reaction, which is going to be your more true anaphylactic reactions, we are saying that levofloxacin 10 to 20 mg per kg is what you're going to give the child if they are truly allergic to penicillin. One thing to watch out for levofloxacin, obviously, we're going to talk about some of the concerns of fluoroquinolones, is the tendon rupture or tendinitis. So as children are growing, obviously their tendons are stretching, so they may be at more increased risk for this black box warning of tendinitis or tendon rupture. So something to be cautious about, but it's not something that you're going to be like, oh, you're a child, I can't give you a fluoroquinolone. And again, 10 to 14 days. If it's a non-type 1 reaction, meaning it's not anaphylaxis, what they recommend the guidelines for is that you do a dual drug combination of Clinda plus cefixime or cefpodoxime. So going with a 3rd generation PO cephalosporin. And the reason why they said not to do a cephalosporin monotherapy, because you're like, why are we adding Clinda when cephalosporins should work just as well? We are seeing a resistance from strep pneumo and H influenza to cephalosporins monotherapy. So that's why Clinda is being added on as adjunctive therapy. Okay, and then if the patient as an adult has a beta-lactam allergy or penicillin allergy, we do have 2 options now. So we still have levo, but doxy is brought in as an alternative. And the reason why doxy is not an alternative for children, although there is some conflict of information with doxy in children, is obviously the bone and teeth discoloration, the bone issues and teeth discoloration in children. So it's not, per the guidelines, they're not saying it's worth the risk with doxycycline. But if you use doxycycline for Lyme disease in children, we're coming out with evidence that we're not seeing those concerns that we thought we were. But I'm going to tell you for now, go with the guidelines of if your child is truly penicillin allergic, go with levofloxacin if they're anaphylactic, or that Clinda cephalosporin combo. And so again, for adults, you have the doxy and levofloxacin. Doxy will get your strep pneumo pretty well. And then your H influenzae will also be added. Levo, again, is going to will definitely get your strep pneumo and your H influenzae. And because these are not beta-lactams, that resistance mechanism that H influenzae has developed will not work against these antibiotics. And so again, I just want to bring up, I know we prescribe fluoroquinolones like water, and it's just easy, right? We're just like Cipro, Levo. The FDA does have a lot of concerns about the fluoroquinolones, and they have released a statement of saying that fluoroquinolones should be reserved in patients who have no other options for the acute bacterial sinusitis, bacterial exacerbation of bronchitis, or UTIs. Again, because we have that black box warning of tendinitis or tendon rupture, peripheral neuropathy. Think about all our diabetic patients who already have peripheral neuropathy, and we're now giving them a drug that could potentially worsen it. We got muscle, joint, and central nervous system issues. We are seeing more altered mental status in our patients, especially the elderly who are prescribed fluoroquinolones. The aortic aneurysm and dissection risk is the newest concern by the FDA, and they are saying hypertension is a risk factor for that. And if you think about all your patients you're treating with hypertension, then no one should be getting a fluoroquinolone. It is super rare to get that aortic aneurysm dissection, but FDA saw enough reports come through that they put it as a major concern. And then the dysglycemia. So again, it can cause hypo or hyperglycemia, more hypo than hyper, but technically either way, your patient's blood sugars can go up or down. So patients that are diabetic on a fluoroquinolone, they may see some variations in their sugar control. So again, the FDA is saying the risk is not worth, outweighs the benefits right now for certain infections. If you are treating a bacterial sinusitis, 48 to 72 hours, you should be following up just to see if it's worsening or getting better. And if you chose because you think this might be viral, like let's do an observation period. You should still follow up with your patients to see, okay, now we've met this threshold to say it probably was viral, but now it may be bacterial. Do we need to start antibiotics? And I'm just going to put this as a quick thing because I'm sure if you're not prescribing antibiotics to your patients, they may be a little bit upset again. They made this appointment with you and you're not giving them anything. The white font is showing the adjunctive therapy that can help with symptoms. So saline irrigation with hypertonic saline, so like the neti pot or that nasal lavage device that's out over the counter now. You can do saline spray, intranasal steroids. So you can do those. Do know that it takes about 7 days to see their max effect. So if you're really trying to help that inflammation up in the sinuses, they may get some benefit, but they probably won't see the max benefit for about a week. And then analgesics and antipyretics for fever and pain related to the sinuses. The guidelines actually do not recommend antihistamines or decongestants just because they do dry you out. And while we think we want to dry you out, if you have a lot of gunk up in your sinuses, but they're saying that drying you out actually is not going to help anything or will not help. It actually may harm things because you actually want the mucus to come out and not be dried up. So they're actually saying that while it may seem like it makes sense to dry a patient's sinuses out with these antihistamines and decongestants, it probably is going to do more harm than good for your patients. Okay, pharyngitis, strep throat, or potentially strep throat. So again, 12 million visits annually. It is more common in children than adults. So if adults get it, most likely they got it from their child. And then the 5 to 15-year-old range is where we're going to be more thinking about bacterial causes versus less than 5, and the adults probably not thinking bacterial as your first line cause. The diagnostic tools that you're going to be doing is going to be your rapid antigen detection test. I'm sure you guys done it in clinic where you swab the back of the throat and then you guys run it in about 20 minutes or so, right? You get the result of yes, it's positive or no, it's not positive. It's 95% specific, meaning that if it is positive, you have a 90% chance that you're like, this is a true positive. However, you can see the sensitivity, which helps rule out an infection. So if it's negative, is it truly negative? It ranges from 70 to 90%. So there is a potential that if you get a negative, that this 30% chance it's a false negative. We do this more in clinic because, again, that rapid turnaround period. It's not recommended for less than 3 years old unless they have risk factors for group A strep, such as an older sibling that has, strep. And we'll go over the other risk factors in a little bit. The throat culture is the gold standard, but why don't we do this on everyone? And that's because it takes up to 2 days for you to get the results. And depending on the situation, you may not want to wait 2 days before starting antibiotics. So it is 90 to 95% sensitive. So again, much higher in regards to the RADT. So its role in practice actually right now is to follow up on the RADT in certain populations. So not everyone is going to get a throat culture if your RADT is negative. And I do want to say the number one cause of pharyngitis is going to be a virus again. It's going to be usually an upper respiratory virus that the patient has contracted. Even some of the, some viruses can give you those like pus pockets or the little white spots in the back of the throat. Because I think a lot of people think, oh, if you see those little white pus pockets, it's, you know, it's bacterial strep. Certain viruses can cause the little pus pockets as well. And then again, your bacterial main cause is going to be strep pyogenes. So again, mostly 5 to 15-year-olds. The adults are going to be probably virus, and the less than 3-year-olds are going to be less than viral as a viral cause as your likely source. So how do you differentiate between the two? You can see again, there is a lot of overlap. The sore throat, group A strep comes on pretty quickly versus viral. You may start feeling some sore throat because you probably had that postnasal drippage that's irritating the throat. Fever, a headache, which can also overlap with the viruses. And then again, the petechiae and the exudates, the little white exudates, it can be in both. It does not necessarily mean that as if you see those pus pockets that you're like, oh, this is definitely strep throat. And then the one thing about group A strep is that you see more of it in winter and early spring. So we are in group A strep season right now versus viral. Again, it tends to ebb and flow depending on its viral season. So the first line treatment that you should be thinking about for strep throat at least is penicillin. It's the most narrow spectrum of the antibiotics. For adults, taste does not matter because we're going to be taking pills. But for children, PenVK, if you're giving them the suspension, not the greatest tasting one. Yes, pharmacy can flavor it, but you may have parents saying, like, my child really is having a hard time taking the suspension of PenVK. So what we do instead is amoxicillin has kind of moved in as an alternative. It is a little bit more broader spectrum than PenVK. And as an antibiotic steward, I'm gonna be like, go as narrow as you can. But again, for especially children, we rather them complete their antibiotic course and not complete it. So again, it tastes better for children. So again, kids may take that more to completion versus the PenVK. But because it is a little bit more broader, you do see a little bit more GI side effects related to amoxicillin compared to PenVK. And then we are seeing a little bit more rashes or that penicillin allergy pop up with amoxicillin than PenVK. And then we have PenG. This is reserved for people that you are like, they will not adhere to that 10-day course. And so you can give them a one-time dose. I will say right now, we are on a national shortage of the penicillin G benzathine, the IM. Pfizer just, there's manufacturing issues. So it's just really hard to come by. And in fact, they're trying to reserve any PenG that we have, that's IM, be reserved for pregnant syphilis patients. So again, it is an option. And until this PenG shortage is resolved, it's probably not your first go-to again, unless you're like, I know for a fact my patient will never complete a 10-day course. But again, you may get pushback from pharmacy if you try to order it for a non-syphilis patient. So the question I have now, again, is this penicillin allergy that you need to think about. So your patient is allergic to penicillin who has a rash. What do you recommend to treat the group A strep pharyngitis? I'm seeing a lot of C's. So again, there's more questions I think you need to ask your patient. When was this rash? So again, was it a childhood rash that, mom told me I had a rash when I took penicillin, and that was 30 years ago? Depending on that and your comfort level, you may be like, I may want to try to challenge it with amoxicillin, but the best answer here is going to be your cefadroxil as your choice. The azithromycin, we're just seeing a lot of resistance to azithro just because we've been dispensing Z-Packs like water. You got a runny nose, here's a Z-Pack. You have a cough, here's a Z-Pack. And so we've just really gotten a lot of resistance to azithromycin. So the azithromycin is not your best option. And then Clinda is reserved more for your true anaphylactic patients where you really don't want to give them a beta-lactam. So again, I'm allergic. If you're type 1, it's either Clinda, azithro, or chlorithro. I probably would go Clinda first over azithro, just again, because of that huge rise in resistance to azithromycin. And yes, I am aware Clinda equals C. diff risk, but there's no guarantee that you're going to get C. diff with Clinda versus there's probably over a 30% chance or 40% chance that you're going to not be treating the group A strep effectively with the azithro. Chlorithro is an option as well. The reason why chlorithro fell out of favor of the macrolide group and azithro rose as king of the macrolides is the drug-drug interactions chlorithro has as a 3A4 inhibitor. So depending on it, obviously children will not be on a lot of medication. So you may be like, I'm going to go chlorithro instead. Chlorithro, just FYI, if you do this suspension for children, very nasty tasting. It may be hard to even mask it with flavoring. But if you have patients on multiple medications that maybe go through the CYP3A4 route for metabolism, chlorithro will flag as a multiple drug-drug interactions from pharmacy standpoint. So you may be getting calls from pharmacy saying like, hey, do you want to do this instead? Or, I'm going to do, what do you think about holding this drug while they complete their antibiotics? For your non-type 1, you go with the beta-lactams, cephalexin or cefadroxil, and these are the first generations. While they have the highest cross-reactivity to penicillin, it's about 5% in the literature. So again, there is a 5% chance that you may cross-react in regards to a penicillin allergy, but for the most part, as long as it's not anaphylactic, you may be willing to take that 5% chance. Factors that influence antibiotic choice that you need to think about. Are they a chronic carrier? Meaning they don't actually have symptoms, but if you, for whatever reason, you decide to test them for strep, they may still pop up positive and they're gonna be like, my throat feels fine. If they are chronic carriers, the question really becomes, do you want to eradicate that carrier or not? And I didn't put it in for time's sake of time, but there are antibiotics that you can use to treat carriers, and they get a little bit more funky in regards to antibiotics than what we just talked about with penicillin or amoxicillin. We even bring in rifampin as a potential, it's a not rifampin monotherapy in combination to try to get rid of the carrier. Prior antibiotic use, again, did they just complete a course of amoxicillin? Because if they did, and they're still symptomatic, do we need to try amoxicillin again, or do we need to try a different one? I will tell you for group A strep in the throat, the US have not seen a resistance yet to our penicillins. If you are like you're worried about resistance and you do test for susceptibilities and it comes back resistant to your amoxicillin or penicillin for strep throat, that is something you probably want to notify your health department or CDC about, because again, that will be our unicorn that we're not seeing in the US quite yet. Adherence, did they complete their course of previous antibiotics if you're treating it again? Or are you worried about adherence again? So you don't think they'll complete their 10-day. Do we need to give them the one-time PenG IM? And then there's controversy or thoughts about if your patient has used antibiotics for acne, are we worried about, quote, this resistance? But again, we're not really seeing that resistance, but it's something to think about of if you are prescribing antibiotics for acne, could that potentially influence your choice of antibiotics to treat strep throat? I'm going to say right now it's a no, because again, I'm not seeing that resistance to strep pyogenes to our penicillins yet, but the guidelines do bring that up as something to think about. Again, 24 to 48 hours, the throat should be feeling better. If you are home with your sick child, they need to be afebrile and at least on 12 hours of antibiotics before they can go back to school. Things that if you're doing the beta-lactam, obviously watch out for allergic reaction, the diarrhea for Clinda to see if this is C. diff. And then in Clarithrol, not only are you doing the drug-drug interactions, which pharmacy will take care of for you, or at least notify you about, but that metallic taste that patients complain about may make adherence a little bit harder. Again, there is no need to test for cure because, again, if they can still be positive and just be a carrier, even though clinically everything is resolving. My favorite of community-acquired pneumonia. So it is the leading cause of severe sepsis and the leading cause of infectious cause of death in children in the adults and children in the US, depending on the severity of the infection. I did want to bring up this triaging tool because I think we've been seeing a lot of, again, since I'm inpatient, a lot of our patients coming in from clinic with pneumonia. And then when I look at them in the chart, I'm like, do they need to be in the hospital? So we do have two scoring systems, the PSI and CURB 65. And again, this helps to triage if you want to take care of them as an outpatient versus do you need to send them to the hospital for further management. So I'm just going to give you, let's see if we can remember this, CURB 65 score of 1, where do you treat the patient? So are you going to treat them outpatient? Are we going to direct admit to IPS? And so be like, Tina's going to take care of you or help recommend the antibiotics there. Or are you going to tell them to go to, they're going to go to ICU? I see a lot of outpatient. So that is correct. So this is your PSI for the pneumonia severity index scale. This is what the guidelines want us to use in regards to for the triaging the patients. It's not as simple as CURB 65, as we all remember the mnemonic for CURB 65. There's a lot of labs and things in here that you're gonna be like, I don't have that information. Potentially, especially in the outpatient setting, you're gonna be like, I don't know. The reason why the guidelines recommend PSI over CURB 65, even though it is more difficult, is that PSI is better or more accurate at predicting mortality than CURB 65. So again, with pneumonia being the leading cause of death for adults in the US, depending on severity, we do want to make sure that we triage our patients appropriately so they get the appropriate care where they're needed. So this is why IDSA is saying use PSI if you can. And depending on the score, you can see outpatient, inpatient, or you can do either one. And then CURB 65, again, very simple. You're like, I can do CURB 65 very quickly. And then scores are either outpatient, inpatient, or assessed for ICU. So I just want to bring up those scores again, just because you're like, they have CAP. Please don't automatically try to direct admit them to IPS. Then cultures. So again, to confirm that infection, we have multiple ways we can culture things. Sputum being the least invasive, and then going all the way to that bronch to the protective specimen brush, so more ICU, going in with that intubated and brushing the alveoli. In the outpatient setting, the guidelines say, do not do cultures, okay? They are saying even sputum cultures in the outpatient setting, if you're saying like, we're gonna treat this outpatient, will not yield us anything useful. Because if you think about how sputum cultures are done, people are just going to spit in a cup and not really get what's deep in the lungs. So for outpatient, there is no cultures that they are saying that we should be definitely getting. Now, as you go into inpatient, yes, we can get sputum and tracheal aspirate, and then ICU will get that BAL and the brush. For blood cultures, only if they're severe CAP, which means they will not be treated in the outpatient setting, or you're going to use MRSA or pseudomonal antibiotics. Again, probably not what you're going to be doing in the outpatient setting. Urinary antigens are for strep pneumo and Legionella are only reserved for severe CAP. So again, not doing it in the outpatient. And then PCR testing for viruses, depending on viral season or concerns for it. You can do the atypical mycoplasma and chlamydia testing if you wanted to, if you're really concerned about an atypical or a walking pneumonia. But again, you do need to get a good sample to PCR that. And again, we're saying in the outpatient, sputum cultures are not yielding anything useful. And then we can test for MRSA with the MRSA NAIRS, but again, that's gonna be more inpatient and you're not gonna be doing that on the outpatient. So from an outpatient standpoint, there is no great diagnostic tool to help you with CAP. So our etiology is going to be for outpatient. As you can see, no matter which setting you are in, outpatient, for us IPS, or if your patient is in ICU, strep pneumo is the #1 cause of CAP. And then you have your 3 atypicals for outpatient, your mycoplasma, Haemophilus. I should have to correct. Haemophilus is not atypical, sorry, but it is your mycoplasma and chlamydia that are your atypicals. H. influenzae is not atypical, and then your viruses. So for outpatient, you have to, there's 2 categories you have to ask your patients to be in. Either no comorbidities or risk factors for MRSA and Pseudomonas. And you're probably thinking, that's not our patients in clinic, because probably all your patients in clinic has a comorbidity of some kind. When we're talking about comorbidities, again, it is just like what I talked about for sinusitis, the chronic heart, liver, lung, and renal disease, diabetes, and then they do include patients with no spleen, so asplenia, and then immunocompromised. The use of antibiotics in the last 3 months, and this part here is IV antibiotics. So it's not even your PO, it's they got IV antibiotics in the last 3 months, or they have risk factors for that drug-resistant strep pneumo. For your rare patient that you're like, they are healthy as a horse, they have nothing wrong with them, and now they have pneumonia, your drug choices are amoxicillin, doxy, or your macrolide, okay? I'm going to say in the US, the IDSA guidelines actually do say macrolide probably is not our choice because it says there, if you have a less than 25% local resistance rate, the US in general is about a 35% resistance rate to strep pneumo with the macrolides. So unless you live in a rural area where patients are not exposed to multiple antibiotics multiple times a year, you're probably just left with amoxicillin or doxy monotherapy. If you think about it, amoxicillin will get your strep pneumo. That is what your amoxicillin is targeting. If you are worried about the atypicals, which happen to be your younger patients, their chest x-rays look a little bit different than, I guess, a standard pneumonia, then doxy will get your atypical. So amoxicillin does not get any atypicals. There is no beta-lactam that gets atypical coverage. And it's great for strep pneumo. If you are worried about the atypical pathogen, then doxy probably would be your drug of choice between selecting the 2. But again, we will probably fall more into that right column. And you have the anti-pneumococcal fluoroquinolone, so that's your Moxi and Levo. Cipro does not fall into that. And then they changed the language from, it used to be a respiratory fluoroquinolone to an anti-pneumococcal fluoroquinolone. And I think that was because when we said the word respiratory fluoroquinolones, everyone thought Cipro didn't get to the lungs. Cipro gets to the lungs beautifully. It really does. The reason why Cipro is not listed here is because it does not have the greatest coverage for strep pneumo. And again, our #1 pathogen we're trying to target. So this is why they changed the verbiage from respiratory fluoroquinolone to anti-pneumococcal fluoroquinolone, and Levo and Moxi are our 2. Levo, I do put the 750 milligrams. That is the dosing we prefer, assuming normal renal function. And if they don't have normal renal function, what you would do is when you look up your drug resource, it start from the 750 dose and reduce it based on renal function there. The preferred way per FDA is that we go the beta-lactam plus macrolide. And we can do amoxiclav, cefidoxime, and cefuroxime. Again, all the beta-lactams are going to get your strep pneumo. The macrolide's coming on board, not for strep pneumo coverage, but it's coming on for the atypical coverage. And then if you can't do macrolide because of QTC prolongation or allergy or whatever, then you can replace macrolide with doxycycline, because again, that will get your atypicals. So risk factors for MRSA or Pseudomonas. It's previous hospitalization and IV antibiotic therapy in the last 3 months. So again, it's not PO antibiotics, it's IV. They have a prior history of MRSA or Pseudomonas infection or colonization in the last year. And then those are the two big ones that the guidelines are saying, like, this is, if they meet this criteria, you may want to cover for MRSA or Pseudomonas. But I'm going to tell you, probably in the outpatient setting, if they truly had MRSA or Pseudomonal pneumonia, they'd be super sick. You would not be treating them in the outpatient setting. And then I put the 3 smaller fonts to say it's controversial. Long-term hemodialysis. This was thought back in the 2007 guidelines when we had HCAP as a category, that because you're going in and out of healthcare with hemodialysis, you're going to be picking up these multi-drug resistant pathogens, specifically MRSA and Pseudomonas. We did not see that, which is why HAP and VAP guidelines dropped HCAP and said CAP guidelines, you address it. And CAP guidelines in 2019 said it's not a problem. We're no longer classifying something as HCAP. IV drug use. It makes sense that we will be worried about MRSA for patients with IV drug use. But again, unless they're doing injections in the chest, like their chest, or I think it was chest popping, where they inject into the chest directly, we are thinking more MRSA in regards to probably skin infections versus actually going to the lungs, unless they're bacteremic, obviously. And then recent influenza. If you are being admitted to the hospital or being treated for pneumonia after having the flu, and the flu has resolved, you're like, this is still not the flu. What we actually found was most patients who do develop CAP after flu grow MRSA. So this is something that you may want to consider if you're like, patient just got over the flu and now you're saying they have pneumonia, and you think it's bacterial pneumonia, you may want to cover for MRSA at that point. Drug-resistant strep pneumo, again, same thing that we've kind of already talked about, related to for sinusitis. So again, the extreme age is young and old. You're immunosuppressed. You've gotten antibiotic therapy in the last 3 months, multiple comorbidities, and then that exposure to child in daycare. In general, it's no less than 5 days for outpatients. So I know you're always like, do we go 5, 7 days? In the outpatient setting, no less than 5, but obviously look for clinical stability. If you are treating MRSA or Pseudomonas or using drugs to cover these bugs in the outpatient setting, you will extend that duration to 7 days. There is evidence, or one study that came out that looked at 3 days of antibiotics. Maybe the next iteration of guidelines may say we can go shorter than 5, but as of right now, it is 5 days for CAP. And clinical stability, again, we're looking at how fast. We don't expect them to be completely asymptomatic in 24 hours. Give them 48 to 72 hours from starting antibiotics. If they're quickly resolving and being clinically stable, then you can say, I'm comfortable with 5. If it takes a while, we're on day 4 and we're still like, we're not making much progress. Yes, you probably want to extend out your therapy. So no less than 5 days, but the previous guidelines also went up to 10 days as well. So depending on your patient's picture, you may be extending out that duration. This is just my little algorithm I made for outpatient. Again, no, this is your probably me or like us who are young and healthy. We may fall into that left category where we can just do monotherapy of amoxicillin or doxy. But your patients that you're going to see in clinic most likely are going to be a beta-lactam plus macrolide, and then your fluoroquinolone, not preferred, but it is technically an option. Okay, we're going to do this real fast with skin and soft tissue. You may see this now as abbreviated instead of SSTI as ABSSI, the acute bacterial skin and skin structure infections. So you have your erysipelas and cellulitis. I'm not going to go into the differences between the two, but from an outpatient standpoint, confirming the infection. It is not routinely recommended that you get blood cultures, biopsies, or even swabbing the infection unless your patient is actively going through chemotherapy, so they are immunocompromised or they have neutropenia. If they obtain the infection through immersion injury, so again, they got it through water. So maybe they went to the beach and they cut their leg, on a rock in the creek or something, then you may, it's not saying that you have to, but you may want to obtain cultures to see because the water pathogens are different than regular pathogens. And then any infections that you come from an animal bite. So severity is going to be for us, you're going to be for outpatient, you're going to focus more on the mild side. And it says systemic signs are absent, which are pretty much, if you look at it, are meeting SIRS criteria. So if they don't have any of the SIRS criteria, you can treat them outpatient. Moderate is saying that you are meeting at least one criteria of systemic signs. And then for severe, it's meeting the signs, plus you're either immunocompromised, you failed oral antibiotics. And I'm going to tell you this one. I think we say a patient failed antibiotics. The word failed really means that you gave them the appropriate antibiotic and they still did not resolve. A lot of times that when we say, oh, they failed an antibiotic, was because they were given an inappropriate antibiotic to begin with. So make sure when you say they failed antibiotics, it truly was a true failure, not because they were prescribed something that was not going to work in the first place. And then signs of deeper infections that may start thinking about, we may be going into neck vash. So the most common for non-purulent is going to be strep. So when for outpatient setting, you are going to be focused in on the strep species. Moderate and severe is where you're going to bring in Staph aureus. And then for severe, which will be an inpatient setting, is when we're going to definitely cover MRSA along with the strep, and then maybe gram negatives or anaerobes, depending on their risk factors for other things. So real quick here, your patient comes back to clinic after you prescribe doxy, 100 BID for cellulitis. There is no risk factors for MRSA, and says it's not improving. What is the reason why they're coming back? Okay, for the sake of time, we're going to say it is inappropriate coverage with doxy for bugs and drugs. So remember, your main concern is strep, okay? Your beta-lactams are going to be your preferred options for strep. So PenVK, a cephalosporin of some kind. The dicloxacillin can be one, and then Clinda if you cannot do a beta-lactam. So these are your oral options. The things with all of these options is that especially the cephalosporin and dicloxacillin, your frequency is going to be probably Q6, assuming they have normal renal function. So adherence may be difficult for patients to go with. And I have been prescribed Keflex for cellulitis. And as a pharmacist, I should know better, but my 5-day treatment for Keflex turned into a 9-day because I could not keep up with that Q6, even with the alarms. So when do you need to think about MRSA? When you have a penetrating trauma to the skin. So if the injury comes because they got penetration from a nail, something, that's when you need to think about MRSA coverage. IV drug use, again, because you are just injecting straight in through the skin. They have evidence of MRSA in the past, or you are meeting SIRS criteria. It does not mean that you have to meet 2. If you even meet 1, technically, because you are going into that systemic symptoms, you may need to consider Staph aureus. And then with our high prevalence of MRSA in San Antonio, you may want to consider MRSA coverage for them. Minimum is 5 days of treatment, and you can extend out that treatment if they're not improving or if it's severe. So again, more in the inpatient setting, we will go 7 to 14. For purulent, we do ask that if you're going to drain it, if there is pus, please collect that pus and gram stain it and culture it. But it does say in the guidelines that if you're treating mild severity, you can treat without swabbing anything. As you can see, severity is same as non-purulent. The only difference is that we added failed oral antibiotics and an IND. Then you're going to go into the more of the severe category. So while non-purulent is most likely strep as our pathogen, for purulent, we're thinking staph, including Staph aureus, as your major choice of pathogen. So with that being said, I'm going to say all of these per the guidelines saying if you can IND it, IND it. Get source control. Now, depending on location of the abscess or things, you may not be able to get the IND, but if you can, get that. And then I am going to say the guidelines don't have trim sulfa or Clinda listed here for mild. If you're PO for moderate, trimsulfa and doxy, as you can see, are our drug choice because we're going to be worried about MRSA. The reason why I added Clinda and Bactrim to the mild that the guidelines don't have is that the guidelines say after a mild SSTI and IND, no antibiotics are necessary. But we have newer studies that show that Bactrim or Clinda for 7 days after an IND for mild purulent infections have lower treatment failure and recurrent abscesses from occurring. And then people were like, well, why not look at cephalosporins to see if that would help? Because we know Bactrim and Clinda are not benign antibiotics. But what they found was that there was not, if you treated with a second generation cephalosporin, it was not any better than IND alone. So again, it's not in the guidelines. So talk to your patient about risk versus benefit of taking trimsulfa or Clinda for a mild purulent infection. Think about your contraindications to trimsulfa, sulfa allergies, CKD, high potassium levels, things like that to make your decision of if you want to add additional antibiotics after an IND for a mild SSTI. 5 to 7 days, again, big thing is get source control if you can. So if it is an abscess, you need to drain it. If you don't have source control, you may be extending out the duration because PO antibiotics have a hard time penetrating abscesses. Almost done, guys. I got asked to cover diverticulitis. Pretty much our main bugs we are worried about are going to be our GI pathogens. So gram-negative, specifically E. coli, and our anaerobes are going to be your main target of therapy. You have your uncomplicated and complicated. Complicated is going to probably move into IPS or into inpatient. Uncomplicated, you can have potentially treatment with antibiotics. And the 2021 guidelines say that doing antibiotics is not routine. So if you are worried about it, you should not just pull the trigger and be like, let's give them antibiotics. But you can consider it if they have comorbidities or they're frail. They have a CRP greater than 140, or they have a baseline count of white count above 15. Sorry, that should be 10 to the 9th. Or you see a fluid collection on CT if you have that imaging. And definitely to initiate it for complicated diverticulitis. So for uncomplicated, because I'm treating E. coli, my gram-negatives, and my anaerobes, you can do a combo therapy of fluoroquinolone, which will get your gram-negatives. And the metronidazole is coming in for your anaerobic coverage that fluoroquinolones generally do not provide. And then, or you can do monotherapy with amoxiclav. The clavulonate adds your anaerobic therapy that amoxicillin by itself does not have. Okay, UTIs real fast. I think the language is very important here between uncomplicated, complicated versus asymptomatic. We have tools for urine analysis. So you have the leukocyte esterase. Do you know that this is not, just because a UA has leukocyte esterase positive or nitrites positive, it does not mean they're like, they have a UTI. We can definitely get false positives and even false negatives as well. And then urine culture, which may take time. So the big thing here is to take away, yes, you will do a UA and you may be doing a urine culture. Talk to your patients about symptoms. That is ultimately what's going to drive us to say we have infection or not. And for the sake of time, we're not going to do this one. But asymptomatic bacteria, we are over-treating patients who are growing bacteria in the urine but have no symptoms. And with that being said, the UTI guidelines are 2011. But in 2019, IDSA specifically created a separate guidelines for this because, again, we are over-treating this. And so what they are saying is, if the patient has no symptoms, but they are growing something in the urine, there's only two populations that we're going to treat. That's pregnant women, and that's just due to the risk of baby. And then if a patient is going for a urological procedure with mucosal trauma expected in the genital area, and we're going to treat prior to the procedure, not after the procedure. If you look at the left side, there's a lot of things I think we kind of say like, oh, we should treat for UTIs, especially the older adults with the altered mental status, right? We're like, they're altered. They must be infected. Let's give them antibiotics. The guidelines say for the older patients with altered mental status, rule out any other cause for the altered mental status before you just jump to infection. The diabetics, again, there's that controversy about are they immunocompromised or not. Kidney transplant recipients, okay? You're like, ooh, they just got a kidney. We don't want to cause issues to the kidney. The guidelines are a little bit more of, if it's been more than a month since their kidney transplant, don't treat. If it's fairly, like they just got their kidney transplant a week ago, we may need to treat them just to try to preserve that kidney. So for pregnant women, we all need to think about risk to fetus. It's not just mom anymore, but you need to think about, if you have dealing with pregnant women, allergies, which trimester the mom is in, and the risk to the growing fetus. And in general, beta-lactams are considered safe in pregnant women, no matter what trimester. And you're gonna be like, Tina, what if they're penicillin allergy? Nitrofurantoin can be used for first and second trimester. We don't use it for third. Bactrim is an option. We don't use this for first trimester, but potentially for second. So you do have other options. You can always look at your drug resource if they cannot do a beta-lactam, but in general, for pregnant women, you probably will be treating them with a beta-lactam. Uncomplicated, you guys know the signs and symptoms between cystitis and pyelo. The big thing is, no matter which one I'm treating, E. coli is my #1 pathogen. And then I do get some Kleb pneumo and some gram-positive Enterococcus and Staph Staphylococcus coming in. And so when you look at our first-line treatment, nitrofurantoin is first line. Trimsulfa, it does have a caveat of if there's more than 20% resistance rate to E. coli, do not use. San Antonio, we're hovering right at 20%, so plus or minus. Fosfomycin, and then you have your alternatives. Pretty much, nitrofurantoin is preferred, but it says do not use per package insert if creatinine clearance is less than 60. We now have some evidence of maybe we can go down as low as 30. It's not due to resistance. The reason why they're saying the renal function is important is when you drop below 30 for creatinine clearance, it does not get to the urine. So you will not get antibiotic to where you need it to get to. Fosfomycin, love it. It's a one-time drug, very expensive. So for our clinic patients, probably not an option for them. And there is conflicting evidence about efficacy related to UTI for fosfomycin. Again, Cipro and Levo are now coming into play for UTIs. Moxie does not get to the urine. And again, FDA is saying really, unless you have no choice, try not to do it. And then your beta-lactams are inferior. So again, in the studies, they did worse than our fluoroquinolones and Trimsulfa. And they're considered alternatives and not as your empiric treatment because of the rate of resistance. If you have susceptibilities, then you can go to a beta-lactam if you need to. But because they are considered inferior, you can see the duration does extend out to make sure we do get all of it. Pyelo for outpatient is going to be 2 drug options, Cipro-Levo or Trimsulfa. Cipro-Levo only if the resistance rate is less than 10%. I'm sorry to say in San Antonio, we are more than 10%. So if you have a greater than 10% resistance rate and you're waiting for cultures to be like, maybe I can get away with it, they do still say maybe to do a ceftriaxone IM or ertapenem IM, or even aminoglycoside ×1 to try to help wipe out that the E. coli, and then do fluoroquinolone to maybe hopefully do some cleanup work. Or your alternative is your beta-lactam again, inferior, so longer duration. And so my main point for all this is saying you have to think about your top 3 pathogens or your most likely pathogens, because that will help you think about your antibiotic choice. And you do need to think about resistance factors that a lot of our bacteria, I'm sorry to say, they're getting smarter than us. They're learning to resist our ways to treat infections. And so you do need to think about your pathogens, and are these pathogens likely to have resistance mechanisms? There are different guidelines to choose your first line. But besides resistance, think about allergies. I think everyone thinks about MRSA. So are they at-risk factors for MRSA? If MRSA is something that you want to think about, to help think about your alternative agents. And then these are all my slides, and I know it's super fast. So what questions do you have for me? I think I saw a few up on top one in the chat. I saw one related to the hip vaccine in pediatrics. So the hip vaccine for pediatrics for acute bacterial sinusitis is for the typable H flu that we have. I didn't go into the dynamics of H influenza. We have encapsulated H flu that the hip vaccine does not do a great job for, and that's where the concern is. But because of the hip vaccine, we are seeing some, like we're not seeing as much H influenza as we did in the past prior to vaccine, but the vaccine is not a solve-all situation because it's not targeting all the different types of H flu. Using cephalosporins for chronic sinusitis. Chronic sinusitis is interesting. There is controversy about do we not treat with antibiotics versus, surgical procedures and other ways to manage it. The cephalosporins, depending on what's causing it, again, if it's H flu that's causing it, we're seeing a resistance to cephalosporin monotherapy. So now you're exposing this H flu more and more and more to cephalosporins that it may become more angry and it may not work. Now, if it's a friendly H flu that cephalosporins work, you may see success with doing antibiotic therapy, but it really depends on which bacteria is up there that's causing that chronic sinusitis. And then for doxy, for the gel for syphilis, the 2023 in the fall, we actually got updated guidelines for syphilis due to this drug shortage to PenG. And they said, unless you are pregnant with syphilis, to go to the alternative of doxy. Doxy is usually 14 days. You can extend it out longer, depending on what type of syphilis you have. But if you are pregnant with syphilis, we are reserving that penicillin for you. And if you're allergic to penicillin and pregnant with syphilis, we are going to desensitize you. That is what the guidelines say. There is no alternative for pregnant women with syphilis. Do we ever consider covering strep and staph for cellulitis? I think, again, for cellulitis, it's not my go-to to cover for staph unless you already have risk factors for that community-acquired MRSA. So again, was it something penetrating trauma? They did drug use. Because in general, it's not the law. So please don't say like Tina said this. In general, staph will create pus. So if there's not pus associated with the cellulitis, I'm not really thinking staph as much. Can it happen? Absolutely. Versus strep is not going to create that pus, which is why it's that redness. If I wanted to do staph and strep, I think I would probably, in that situation, there is no one drug. You're going to have to do that combo. And sometimes you will see me in IPS saying like, we don't have cultures and they improved on VANC. I don't know if because it was MRSA or not. You'll probably do a beta-lactam for your strep coverage, and then you'll either add doxy or Bactrim for your staph coverage for if you want to treat both. Any other questions? So there is, the comment is related to overuse of antibiotics and gut microbiome. The microbiome world for gut is like blown up recently prior to Princess Catherine and her issues. Because we are finding more and more information about using our gut flora microbiome to help us with treating infections, not only C. diff, but just overall health in general. And yes, the overuse of antibiotics definitely will kill off some of our natural gut flora, which is why C. diff is always a concern for us, because then C. diff can thrive and cause that infection. It relates to cancer. I'm not an oncology pharmacist. I didn't look into that evidence recently, but I think there is a lot more information or studies being done, and everyone is all about probiotics and restoring your gut flora and creating a healthy microbiome because of this, again, association with just general overall health. And just do you remember, there are few, like nitrofurantoin, if you're going to use it for UTI, it only goes to the urine. Like it only kills the bacteria, the E. coli in the urinary tract system. It doesn't kill our E. coli in our GI system. So you do need to think about your collateral damage your antibiotics are doing, because again, we do have some friendly bugs that are not causing infections, even though they're the same type. You're like, oh, I'm trying to treat E. coli, but and it's not in the GI system. again, you may be killing off some of the natural flora that's in our gut already because of how broad spectrum we are going with our antibiotics now. So it'd be interesting to see it. And I'll have to look into more about related to the cancers on the gut biome. And then let's see.
Thank you, Dr. Beck. That was great. Thank you.
Any other questions? Again, I know it's super fast and I try to keep it very superficial, or not super, but 50,000 foot view. But I'm going to tell you again, think about clinically, what is your patient doing? And what is going on with them specifically, instead of trying to slap a generic empiric, like this is what the guidelines say, and I have to do it.
Dr. Beck,
Thank
I wanted to ask one more question. Are interprescription periods considered as part of the whole therapy regimen? So maybe a vulnerable individual who has a UTI and then a respiratory infection and then has a recurring UTI. They're bouncing back and forth across various.
I think that's one thing to think about is if they're going back and bouncing back and forth, what antibiotics were we using to treat one infection? Because that can impact your choice of next, depending on what the next infection is. That can play a role on that. Because again, if you were exposed to amoxicillin and your next infection is, you're like, oh, the guidelines say it's amoxicillin, that bacteria has been exposed to amoxicillin already, even though it wasn't causing an infection when you were using the amoxicillin. So again, our bacteria are becoming way smarter than we are. We're having a hard time catching up, actually. And so there is a good chance that they're going to develop resistance. So you may prescribe amoxicillin, but you also may see more treatment failures. I didn't put recurrent UTI treatments, but we do have ways to prevent or prescribe antibiotics to prevent recurrent UTIs. But if they keep bouncing, I do think you need to think about always think about their previous exposure to antibiotics and how that can impact your next choice. In general, depending on the infection you are treating, some will say, think about your antibiotic exposure in the last 30 days, and some will say in the last 90 days, and some will say in the last year. So you, depending on which infection you're treating, you do need to look at the guidelines of, like, I took a Z-Pack 5 years ago. Is that going to make a difference? Probably not. But versus if I took a Z-Pack last week, that may make a difference if I come back for a different infection this week.
Again, excellent presentation. Wonderful.
Thank you, Dr. Beck. Some residents were asking if you could share the slide.
I will send it to Kelsey, and then I don't know if she can distribute as needed.
Yeah, or you can send it to Ari.
Okay.
You can send it. Thank you. Thank you so much.
Guys, we'll see you at the didactic. Thank you, Dr. Beck.
Thank you.
Guest speaker coming in. Thank you.